So welcome back again to It's Worth a Shot. I feel like we need to have an opening theme song now, since we're like a regular must-see TV every week. Today we're going to be talking a little bit about the nursing home blanket waivers that expired. And so we're going to hear a little bit about from Kelly OLeary, who works state epi DOH for both Alaska and Hawaii. We're going to hear a little bit from her about some issues that pertain to those blanket waivers. And then we're going to have a question and answer, and hopefully Matthew Thomas from the Alaska State Survey Agency will be able to join us, so we can, I'm hoping we can have a good dialogue with Q&A about those issues. Next slide. All right, so just a few housekeeping items. Please add your webinar topics and any ideas or needs into the chat. We've been getting some really great suggestions for future topics that we gather both from our conversations with you, but also if you let us know here. And we're just gonna keep this rolling every Wednesday, at least through the end of the year. Next slide. I believe now we have a polling question. This question is just to help us get some information on where you stand. So if you could throw in, how do you feel about the amount of information that you're getting on COVID-19 vaccines? Another second here. All right, looks like most of you feel like you're getting enough information. That's, here, do I share? What do I do? I'm not used to the polling windows, if you could see that. But some still feel like you're not getting enough information. Nobody feels like they're getting too much, but sometimes I feel like we get too much. Thank you. Next slide. So of course, big thank you to all of the folks who speak with us, our collaborating partners, folks that are still continuing to attend and support the needs of all of our facilities across our regions, and those, of course, who are doing the boots on the ground work. We appreciate all of you. Next slide, please. All right, so, sorry, small plane in Alaska. We wanted to talk about the expired life safety waiver because we've gotten several questions kind of along the lines of what we have in here since that blanket waiver went into place. And so a couple of the things that we get is, now that it's ended for the hallway barriers, the life safety waiver, is it okay to put plastic barriers up when a COVID-19 positive resident is being cared for in the ward, or is there another waiver they can apply for? And then questions about what life safety will be looking for during your survey and what could be or has been cited as deficient practices. And are there other considerations, like what does fire marshal have to say? Those are the types of questions we've been getting that we wanted to speak to today. Next slide. So I'm going to introduce, first we'll have Kelly OLeary, who is a fantastic partner. Like I said, she supports both Alaska and Hawaii. And she has been on, I think, a couple of times before, and we've got her slated for a couple of times later. That's what happens when you're a willing partner and do such a great job. We end up tapping you continually. So take it, Kelly. Thank you.
So with respect to barriers, thinking about now, it's not okay to put up that big construction plastic barrier. I wanted to make sure that we spent a little bit of time on the isolation guidance, particularly that section around patient placement, because we've been trying to move away from red zones into more of that transmission-based precautions thought. And then isolation guidance also just got updated May of 2022. So go ahead, next slide. And this guidance is referred to in the conditions of participation. This should be in your bookmark, printed out. It's actually 200 pages, but you can highlight in a PDF now. So this is a very important document that you should be pretty familiar with and can refer to often. So it just got updated May 2022. Go ahead, next slide. So the section on patient placement, I just highlighted some of the parts that I just wanted to make sure we talked about. And, facilities that still want to do a red zone, it is okay. But I wanted to just make sure that you are familiar with the parts in the isolation guidance that remembers how to do transmission-based precautions again. So, and we also know that every long-term care facility is challenged with space, and that you have multiple patients in single rooms and may not have single rooms available. Pricing issues are also an issue, where in Hawaii, we've actually had a facility downgrade their census from 70s to about 50s. So we know that there's some even backlog in hospitals because there's no room in long-term care. Anyway, with that said, so single patient rooms are preferred when there's a concern about transmission of an infection agent. So there's that word preferred. So if you do have a patient with COVID or with some other multi-drug resistant organism, that is going to be your first thought. Can you have this patient be in a single room? If you can't, then it's acknowledged in that second highlighted area that when long-term care facilities do have multi-bed rooms, then you need to start looking at different or considering different things before you are gonna either put a roommate into a room, or who's that roommate with that positive COVID patient, who's that roommate with that positive MRSA patient. So, and I know that you guys have done this before with, you guys are probably pretty good with MRSA on that, C. diff, flu. But you guys are more challenged these days, where you may not have that red zone capability anymore, or you are transitioning back to transmission-based precautions. So all these things you should be considering when you're looking at movement of patients. And then the third highlight, when there's only limited number of single patient rooms, again, you're looking at what is the organism that the patient has, and then is it in a wound? Is it in their sputum? How transmissible may it be? And what's that risk? So we've brought up risk recognition. I can't remember in which meeting, but that's kind of the new buzzword with CDC. Lots of great training resources on Project First Line CDC website about risk recognition. So it's really trying to figure out what is that risk to that negative patient? What's the risk if you don't move a patient to a red zone or to a private room? So, there are risks to moving patients as well. And that has been shown. And even with COVID outbreaks, it's kind of hit or miss if that roommate's going to turn positive or not. So it really is dependent on how good your infection prevention practices are. And when you do have a multi-bedroom where you have a positive and a negative patient in a room, that's a good time to be doing increased hand hygiene, increased PPE audits if you're able. Next slide. The next section in this guidance is particularly around cohorting. And so I'm certain that you guys are familiar with that word because we've been talking about it the last couple of years. But the idea of cohorting in that red zone or a yellow zone. So that's, clumping like folks together. So even, back in the pre-pandemic, you'd put a couple MRSA patients together. So it's putting folks that have the same organism together, and it's generally not preferred not to put, for obvious reasons, a severely immunosuppressed patient with somebody with a multi-drug resistant organism, or even maybe with COVID. And so I really liked this last sentence. And so it said, cohorting often is implemented only after routine infection control measures have failed to control an outbreak. And what we're seeing now is kind of 1-2 cases in staff, 1-2 cases in residents. We're not seeing a big explosion in cases now where, yeah, a red zone may have been appropriate. Even though you still meet the definition with 1 case in a staff or 1 case in a resident for technicalities, outbreak, now you're in outbreak mode. It's not an outbreak in the sense that you have facility transmission. And you may have facility transmission. That's when you're gonna wanna maybe speak with your Department of Health to see if there's anything that maybe you could be doing differently. But the idea of cohorting, you don't necessarily have to have a red zone anymore. Go ahead, next slide. I know some facilities still feel like it works for them, and that's great. You know, we're not suggesting that you change it if it works, if you have the space, if you have the staff. Most facilities that I've been working with, they're in that contingency staffing level area and right on the verge of crisis staffing. So to think about moving folks, you really want to think about, is the juice worth the squeeze? Appendix A in this isolation guideline is a great document. It's an A to Z listing of every single bacteria, virus, and the recommended precaution level, the duration of precautions, and then any notes that may be included. So great document. I just printed it out and had that as a reference. And you can also take some of your norovirus, maybe monkeypox now, MDROs. You could create a little cheat sheet for your staff, if those ones that you see the most of, because it's a very long document. Anyway, SARS it got updated. You can see that the precaution levels are airborne droplet contact standards. So that's basically you're wearing all the same PPE that we're all familiar with. I want to just point out here, they have specified that airborne is preferred. So that's, the dedicated exhaust, rooftop, HEPA filter, UV light. Long-term cares don't generally have airborne isolation rooms. So I like that they clarified droplet if airborne isolation room is unavailable. It's a little confusing because droplet normally means surgical mask, but in this instance, they've clarified the N95. And I just want to highlight too, even though long-term cares don't have that airborne technical room, you're airborne in the sense of the N95, which then means that you must, according to OSHA, have to have a respiratory protection program. So I just have to put that out there, not to forget that respiratory protection program and to ensure that you have that, because that's kind of a red herring for surveyors these days is show me your respiratory protection program. How are you keeping your staff safe? Next slide. So here's some pictures, and these are ones that we took at Hawaii Department of Health when we would go out on some infection control assessments and responses. And I just bring these for discussion purposes and hope it just gives you some ideas of, this upper left-hand corner with the big construction barrier. That's what the waiver is saying, is you no longer need that. Life safety code is saying this is a big issue, and so can't have these up anymore. So big blue X. I wanted to just make note in this picture too, and was gonna have it as like a little quiz, but you see the circle on the sprinkler on the ceiling? Can anybody tell me what the problem is with that? You can just put it in chat. So we're going to bring up a couple environment of care concerns in these pictures. Okay, fire hazard.
Kelly,
Yeah.
this is Matthew. I'm on the call too, just so you're aware.
Great. Okay, great. Yes, it is a fire hazard in the sense that that sprinkler is not going to be able to spray anything beyond that barrier wall. So it does pose a hazard. And when we were reviewing these with Matthew, he's like, I'd cite that. So it was great to be bringing up some of these environment of care things that nursing staff, infection preventionists, may not always think about. The bottom picture below that, the next blue X, as we are going into facilities, we're seeing these signs still up. And so the sign was up, but there was a mixture of a positive patient and a negative patient. So it really wasn't a green zone. So I just highlight making sure that you're refreshing what you have hanging up in your hallways. Another red herring for surveyors. So, but also we want to make sure that your staff is aware of, what's happening in this room, this hallway. The stop sign picture, that is in a memory care unit, that is into a room. So has a couple bays or a couple beds in there, and then a bathroom to the right. That's for obvious reason, trying to keep your memory care patient safe, not traveling out if not. So Matthew brought up, is that in a suite or in a room? But it's a room. So maybe in chat, what would have been the issue if that mesh stop sign was in a suite? So maybe you've opened up the fire doors and you have that across at the beginning of a hallway. What would be the issue?
And Kelly, once we get some responses, and if we do, I can speak to that a little bit about what we talked about prior to this.
Yeah, yep. And if you want to bring up anything with the sprinkler too, or anything more about the barrier.
Yeah. Well, while we're looking for some responses, I'll go back to that first picture where there was the sprinkler. Is that obviously that sprinkler is going to hit that plastic barrier and it's not going to spray what's beyond that. So I would look for another sprinkler within that barrier. In addition to, if that barrier is in a path of egress, and let's say there's an exit sign within the affected area, you have lost all visual of that exit sign, for example, and you would have to install another one outside of that barrier to show that that was an exit path. Again, these are just hypotheticals, but these are things that we look for. So when you guys do infection control risk assessments or change things or put any type of barriers up, whether it be that stop sign or not, I would highly encourage you to pull in your facilities director or your life safety code specialist and have them do an evaluation too. That could save you life safety code citations or even IJs. We'll quickly go over the stop sign. These things I've seen over exit doors that actually can be cited for impediment of egress, because you have a big stop sign saying stop, pretty much don't enter, don't go. And you can't do that. If you can do these on resident rooms, this one's installed correctly on the outside. They're designed to, if the resident is in the room, they should be able to push through that in an emergency and pull the Velcro off. If it was reversed, the Velcro is not designed to go to go that way. It's supposed to go from the back of the sign out. I don't know if that makes sense or not, but those can cause a lot of issues. But majority of the time I've seen them used correctly. But just remember, don't put them in any suite doors or fire doors or exit doors. I'll turn it back over to you, Kelly, and I'll be here for Q&A.
Yep. Just some other pictures. Some facilities, have a little yellow sticker, and that just indicated that patient was, on quarantine, and for the staff to wear the appropriate PPE. And, there's always a cart outside the door with the PPE and a sign on the door as well. But that's also another indicator. And, maybe it's A bed, B bed. So it's trying to just define. So these are just some alternatives to think about. This, and maybe you're keeping up some things. This was during an outbreak, and where it goes into the kitchen. So it was kind of demarcating that kitchen staff weren't to cross over. And, so this is where the tray cart would pass through. And so some practices like that you may keep. I would just highlight, as an infection control person, I'm going to want to know, how are these being cleaned? How are you cleaning the floor? So it might be that you need to take up the tape and clean it on a regular basis if you're leaving it. And same with the bottom picture with the yellow and the red. These are older pictures, but it's just giving you an example that if you still want to use your red zone or still have the capability of moving folks to a single room, that you can demarcate the floor, that it's a red patient, or, you know, that you need to, you're just highlighting that it's a red room. And then the yellow, you know, could be your what used to be a construction barrier. You just have that area where maybe you're going to don your PPE and doff your PPE. And then the just the far right picture is just another example of where they did have it sectioned off for their red zone, and how they just demarcated it on the wall that now from here forward, you're in a red zone area. And that would be a good example for not using the barrier. So I wanted to just check in the chat here. Let me just see.
There's a comment about having a hard time leaving a COVID positive resident in the shared room, especially since there isn't any prophylactic treatment. And the estimate is that about a third to a half of the roommates of a positive end up converting. And I know I hear that a lot, and then folks will be moving people out, but then see it progress. And so that decision of how do you handle those disparate folks?
Yeah, no, great question. And it has been interesting to even look back, and those line lists are actually very helpful in trying to look back and see, what's happening. And I need to follow up with a facility, just because I'm starting to see some roommates turning positive. It's interesting to see that time frame. So this is where your infection preventionist or your Department of Health can help you kind of look at your data, and how the line lists are so helpful to see your facility specific. There is, unfortunately, the roommate has already been exposed to that positive person, and we'll talk COVID. And so, we do want to think about lessening that chance of transmission. So that's now where we have to think about movement within that room, PPE within the room, hand hygiene. Unfortunately, COVID, the variant is, I look at it as it's a COVID cloud. It's long-term cares don't have good ventilation. So I open up windows. You really do want to try to increase ventilation where you can, especially if you are in a situation where you have two roommates, or roommates in a room with one positive. And the prophylactic treatment, they do have the antiviral, the Paxlovid. So there is antivirals that folks can have. There's less of the I'm blanking, but the other medication that we would give folks, just because it doesn't work on the variant anymore. Only if positive, not for prevention. And certainly if you have the capability of moving folks to a private room, that would be the ideal. So we're just trying to let you know that the guidance is allowing you to have COVID be under transmission-based precautions, and looking at your facility demographics. I think that's the only. So the last slide, if you can go to the next slide. If you're really in a pickle and you're just not quite sure what's happening and how many residents are positive, and you're concerned there's facility transmission, or you just want to run something past the health department, I recommend a risk assessment be completed. And it's really that you're looking at things in a really thorough way. And if you were to, it's like documenting your thoughts, you're documenting your discernment process. And I feel like that's a good way to show a surveyor that came into the building that you have really thought about this. And that if you don't have a red zone and you do end up having some residents that turn positive, you've really done the best that you that you can. And so this risk assessment, some things to consider: staffing level. If you're in crisis staffing, you know, it's going to be really challenging to be moving a lot of people. So, you know, we can empathize with that. So staffing level, facility layout, how many you have in a, you know, shared rooms? Do you have any private rooms available? Risk of transmission to others. You know, maybe you can't move, but you do have a fairly healthy resident sharing that room. So you might feel a little bit more at ease. The risk of vaccination rates, you know, if you have a high vaccination or booster rate amongst your staff and residents, I'd feel a little good about that. Community transmission level. You're going to have to ebb and flow your plan based on that community transmission level. So, you know, if it's really low, maybe you might be able to leave a roommate in the room or not feel like you have to move residents out. So lots of things to be considering. Call us if you want some help. If you go to the next slide, it's just an example of a risk assessment that I've used in the past with some facilities. There's lots of examples out there. You might have already one that you use for your facility. So I would just encourage you to fill one out as you're trying to look at what's the best patient placement, depending on the cases of COVID you have in your building. And that's it. Any questions? I'm hoping that answered some of the questions that you got, Dana. I know some of them were regulatory, so now's the Q&A. Thank you.
Yeah, does anybody have anything they want to run by either Kelly or Matthew from the survey standpoint? Of course, he surveys in Alaska and can't necessarily speak to what your state team would cite, but generally speaking, the direction they have from CMS anyway. Don't be shy.
This is Jennifer in Petersburg. Hello,
Jennifer.
Matthew, and this question's for you. We have some screens. They're rolling screens that you can, you know, pull out, push in. They are below the sight line of the exit signs, and they easily move. If you touch it, they roll away. So I'm wondering if that is an acceptable barrier in a hallway for actually, and for Matthew, going from our long-term care to our acute care, used actually more to help, you know, our people who wander to just kind of turn around there. But you can walk through it. I mean, you can't walk through it, but you can easily push it out of the way and you can still see the exit sign.
Hey, Jennifer. Yeah, I actually remember the screens that you're talking about. My initial gut is no, I don't think they would be a problem, but are you planning on using those regularly?
Potentially.
Jennifer, I'd have to think on that a little bit more, but like I said, I do very distinctly remember seeing what you're talking about. I mean, it is something that's in the corridor that's visually could be a visual blocker, but I do know that they're very easy to push because I've actually pushed them myself. So
Yeah.
can we follow around with that, you and I?
Sure.
Okay.
Yeah, thank you.
You for sure want to make sure it's getting cleaned and disinfected on a regular basis.
You don't have to be from Alaska if you have a question, or Hawaii.
I have a couple questions that came up that maybe might help spur some other examples or questions.
Right.
So Matthew, this is for you. So that stop sign example, what if, and it's maybe like the plastic half wall barrier, but that stop sign with the mesh was covering an exit door. So the memory care residents wouldn't walk out the door. And I don't know if there's an alarm or not. Maybe there's not an alarm, maybe there is. So is that okay?
No, that is not okay because a lot of people automatically assume that impediment of egress is like something in front of the door, like a chair, or something's locked and you can't get through. If it's a memory care unit, there are regulations in place for that, such as delayed egress lock or locking for security measures. So if you put on that stop sign, as I mentioned earlier, you're giving a visual impediment. So things don't always have to be physical necessarily, but visual. I've seen people put up signs saying, stop, do not enter, whatever, this is a secure area, but it's actually a exit stairwell. And I've cited that before because you cannot stop people from going through that. So to answer your question, Kelly, that is a very easily citable offense to put that on a exit door.
Okay, thank you. And I think we're timed, so no.
Yeah, we are at time. Unfortunately, thank you so much, you guys. Matthew, I guess would a good summation be that probably the majority of the citations for this sort of thing are just blocking egress or blocking the exit sign, so folks know where the egress is.
Yeah, I mean, really quickly, obstruction of egress is the most primarily common deficiency. Then secondary to that would be the sprinkler coverage, and then also visual of exit signs.
The coverage.
Yeah.
Good thoughts. So there's 3 good takeaways. So we've put the evaluation link in the chat. We'd love it if you would complete that for us so that we know how we're doing and how we can best continue to tweak this so that it meets your needs. Thank you so much, everybody, for being here. It felt like that flew by for me. And we will see you next week.
Thank you.
Thank you, Kelly and Matthew.
Thank you. Have a good day.
Thanks.
Yeah.